a very, and I will say it's been a very active year or two, I should say, in endometrial cancer. And just, to introduce myself, I am a gynecologic oncologist. I work at NYU Langone. I serve as the medical director of the clinical trials office there. I also run our gynecologic oncology clinical trials program, and I wear a couple of hats nationally as the Associate Clinical Trial Advisor for GOG Partners, as well as the Director of Diversity and Health Equity for Clinical Trials. So you're going to hear a little bit about some of the work I do today because I am so passionate about it. So I'll ask you to bear with me. Here are my disclosures. And given all the work I do in clinical trials and bringing new medicines to patients, I think it's important that I share these. So today I'm going to walk you through the management of endometrial cancer, not just frontline, but also beyond. We'll talk about the background, the molecular classification, and the current standards, some recent advances in treatment, future frontline treatment options and ongoing trials, and then recurrent endometrial cancer treatments. So I think most of you are pretty savvy in terms of endometrial cancer. Currently it is the most common gynecologic cancer with over 66,000 new cases. And 13,000 deaths that are estimated in the year 2023. The majority of these, over 2/3, are early stage and have excellent prognosis. About 1/3 of these are high grade and more advanced. The other thing to note about endometrial cancer is that it has been increasing both in incidence, so number of cases, as well as mortality, and so the number of deaths. And we think that this is largely due to, the mortality is largely related to the increase in aggressive histologic subtypes, such as the papillary serous and clear cell subtypes, as well as carcinosarcoma. The rising incidence is due to the obesity epidemic. And so with that, we are seeing a greater number of endometrial cancer cases. So as I alluded to earlier, ovarian cancer used to always be considered to be the most lethal of gynecologic cancers. However, a recent publication showed that the mortality of ovarian cancer is actually decreasing, and that of endometrial is actually increasing, and endometrial cancer is soon to surpass that of ovarian cancer. And we think, as I said earlier, a lot of this is due to the disproportionate increase in the aggressive histologic subtypes that are more common in non-Hispanic Black patients. And you can see that on the right here as well. And so this became, a big splash where it was even highlighted in the New York Times. And I'm really glad it was highlighted because it brings us, brings everyone to really understand that this is a real problem. The burden for Black women has increased disproportionately, and it reflects a significant racial disparity in cancer. And, these aren't just explained by histology and stage. So clearly, there's a lot of work to be done in mitigating racial disparities, which brings me to, I'm going to talk just briefly about some of the work that I am really passionate about is increasing the enrollment of diverse patients onto clinical trials. And this is really important, and hopefully I'll show you why. So I think the one thing that is really important is to understand that when we do a clinical trial, what we're trying to do is identify a population that's going to really represent the population as a whole. And so this really relies on the expectation that the data that we get is representative of the population in all ways that are important for the medicine and its indication. And it relies on the fact that these results can be generalized and will provide information to a larger group than that was initially just studied. However, we know that study populations vary by institution and cancer type, and patients from minority racial and ethnic backgrounds are consistently underrepresented. For example, Black patients represent only 15% of people with cancer, but make up only 4 to 6% of trial participants. And similarly, Hispanic patients represent 13% of people, but only make up 3 to 6% of trial participations. And less than a third of trials actually even report on race and ethnicity data. And so this underrepresentation is likely even more extreme. And finally, phase 1 trials particularly do not represent the population with the greatest medical need. And when this happens, the phase 1 trials are the early studies. So if they're not represented here and there's a particular drug that is more effective in certain populations, it may never even be identified and may never get to the later phase, which really continues to exacerbate health disparities. So we need inclusive participation in trials because we want to reflect the racial and ethnic diversity of the population expected to use the medicine. We want to understand the potential differences in safety and efficacy, and we want to help mitigate racial disparities in health outcomes. And ASCO actually states that access to clinical trials is a critical component of high-quality cancer care. I don't want to spend too much time on this, but there are different reasons for not achieving diversity and health equity in clinical trials. Some of these are clinician barriers with bias, limited time, patient barriers with a limited educational background, limited by financial barriers, distrust due to some earlier historic atrocities, language barriers, institutional barriers in terms of access to trials, and diversity of research staff, which is really important when people see other people that look like them and can relate to them. So making something that is scary like a clinical trial just much more to really normalize it and to make patients feel comfortable about participating. And then there are trial barriers with very restrictive eligibility criteria and numerous visits, some of which, may or may not be necessary, and also thinking about telehealth and safety visits via telehealth. This became such an important issue that ASCO and the ACCC joined together and put out a research statement that outlined 6 key recommendations to help mitigate some of these racial and ethnic to improve racial and ethnic diversity in cancer trials. And recently, we joined, the GOG and SGO joined, and we put out a paper on inclusion, diversity, equity, and access to clinical trials. And the reason I spent all this time on this is because it's so important. And I hope, as I show you the data and, what we've accomplished in the last year or so, I should say in the last few years, all these advancements really come from clinical trials, and it's really important that we have good representation. So I'm going to next spend just a few minutes on, how we now look at endometrial cancer, and many of you are probably already aware of this, and then just highlight some of the new discussions about the FIGO new staging. So, endometrial cancer used to always be thought of as a very simple disease, and it used to be 2 types, type 1 and type 2. Whereas the type 1s were related to estrogen and the type 2s were more of the high-risk histologic subtypes, the clear cell serous mucinous. And, these had worse prognosis when compared to the garden variety endometrioid that had more favorable prognosis. So now, instead of those two dichotomous groups, we now have four distinct molecular subtypes. So we have on the left here what we call as hot tumors, and those are the ones with the POLE mutations, as well as those that are microsatellite instability high or deficient in mismatch repair. And then on the right, we have copy number low. These are the, what we usually consider as the grade 1 endometrioid type. And then we have the copy number high, which are the more aggressive, higher risk histologic subtype, and they can be characterized by abnormalities in P53, whereas the copy number low do not have P53 abnormalities. And then this study is nice because it shows us why these molecular subgroups are important. It's because they actually are prognostic, meaning that the different subgroups, patients do differently in terms of their outcomes. So the POLEs do the best, and you can see that both in terms of what we call recurrence-free survival as well as overall survival. And then the worst are the copy number high. Again, very similar in terms of recurrence-free and overall. And in between are the intermediate, the DMMR or mismatch repair deficient, and the copy number high. So, the other thing about some of these markers is maybe they are predictive. And, we definitely know that for, P53. I think this needs to be really borne out a little bit more because this was just identified in PORTEC-3, and it was obviously a retrospective look at it. But the P53 abnormal ones derive the greatest benefit from chemotherapy. The POLE, they do well regardless of treatment, so probably don't really get a whole lot out of adding chemotherapy. And then the same with mismatch repair deficient, there does not seem to be a benefit from chemotherapy, but I'm going to show you later that there is they are exquisitely sensitive to immunotherapy. And then your non-specific molecular, they didn't really have any statistical benefit either. Again, we have to take those with a grain of salt because they were all done retrospectively, and they were not, these findings are all interesting, but they're truly hypothesis generating. That being said, molecular classification is important because I think it is safe to say it is definitely a prognostic factor, like I showed you. It can help us with risk assessment. So if you're POLE, we know that you're going to do well and likely not recur, and so we can probably de-escalate therapy. We also know that it can be a predictive factor, like, having a mismatch repair deficient tumor means you're going to do better with immunotherapy. And I'm going to show you some of the data in the Frontline that, was recently presented this past year. And we now have approval in the mismatch repair deficient in the Frontline setting. So with dostarlimab and chemotherapy. So I'm going to show you that data. And finally, molecular testing is important because it can help us screen patients for Lynch syndrome. And so that's why at our institution, all our patients have mismatch repair IHC done, at the time of their surgery. And if that is abnormal, then they may get referred to genetics. So, these are very new updates in terms of the endometrial cancer staging. So the FIGO now is proposing a new staging system, and the ESGO-ESTRO ESP guidelines that were put out in 2021 and the ESMO clinical practice guidelines both take into molecular subgroups now. And, the two biggest changes in the molecular staging are that they did two things. One, they identified good prognosis, intermediate prognosis, and poor prognosis. The good prognosis were the POLEs that we showed you. The intermediate were the microsatellite instability high or DMMR, and the non-specific molecular group. And then the poor prognosis were the P53 abnormal. The other thing they did was they took this and they incorporated it into molecular staging. So the POL-E mutated patients, regardless of whether it extended down into the cervix or within the muscle of the uterus, they were called a stage 1A with the molecular classification of POL-E mutant. And they just essentially did this because these patients do really well. And then the other thing that they did was any P53 abnormal endometrial cancer, even that is confined to the uterus with any myometrial invasion, without cervical invasion, regardless of LVSI or histologic type, gets upgraded to a 2C. So you may have just, a P53 endometrial cancer that would have normally been a 1A, but now gets upstaged to a 2C molecularly profiled P53 abnormal. So these are the two main differences in the updated staging. Now, we don't think that this staging is ready for prime time yet. It is currently being vetted by our pathologists, and we do need to kind of get buy-in from everyone's who is involved before we can accept this staging. But I think it's important to know that this is out there, and it was now the FIGO staging has been published. So where are we with frontline therapy, and how is that going to, and what advancements have we made? So this is our standard, GOG 209. This trial looked at carboplatin and paclitaxel and compared them to 3 drugs, doxorubicin, cisplatin, and paclitaxel. And so this was what we call a non-inferiority trial. So basically, we wanted to show that the two were the same, and we could get away with utilizing 2 drugs because it's going to be less toxic. And that's exactly what we were able to show. When you see curves where they are they mirror each other, you can see that there's no difference between the 2 and the 3 drug, both in progression-free and overall survival. And when you look at the numbers, they're quite similar. So this trial established that we could just use paclitaxel and carboplatin. And so how do we build on that? So there have been several trials that have utilized the chemotherapy backbone of paclitaxel and carboplatin and added an immunotherapy drug. Here are 2 of them, NRG-GY018 that added pembrolizumab, and then Ruby, which added dostarlimab. These were 2 trials that were reported at this past year's SGO meeting, and really both were positive phase 3 trials. So really changing the standard of care in endometrial cancer. So let's talk about the mismatch repair deficient, or the MSI high tumors. So though in the GY018, you saw that there was a marked difference with the addition of pembrolizumab to chemotherapy. And you saw, when you have curves that are this separated and you can kind of drive a truck through them, this is a positive trial. And then same here, you can see beautiful separation in the curves with the addition of dostarlimab. And I don't think we need to focus on the numbers, but I think the picture tells it all. So, I just want to go back here 1 minute. So this regimen is now FDA approved, and it is now considered a standard of care in mismatch repair deficient endometrial cancer to get dostarlimab added to your chemotherapy backbone in the front line. Pembrolizumab had similar data. We're just waiting regulatory approval, but clearly both showed very similar data. And then I'm going to show you some additional data with some combinations in a bit. But before I do that, so that kind of brings us to, well, how do we know that we wouldn't have achieved that with just pembrolizumab in these mismatch repair deficient tumors? And so, we have several studies that are looking at this. GOG 3064 is looking at pembrolizumab randomized to chemo. The Dominica trial is looking at dostarlimab randomized to chemotherapy, and the LEAP 001 trial looked at the combination of lenvatinib and pembrolizumab, against chemotherapy. And we now know there was a recent press release just this past week that said that this trial did not meet its primary endpoint. So it looks like this one is not going to be in the running, but certainly these two are still, the data is maturing. And so hopefully we will have an answer soon, whether we can just use pembrolizumab or dostarlimab. Now moving into the mismatch repair proficient, group, I think this is an area where I think there's still a little bit of work to do. You can see that the benefit, this is in GY018 and this is in Ruby, is not quite as marked or robust as it is in the DMMR. That being said, GY018 was a trial that was designed specifically to look at whether there was a difference in this specific subset. And it was, it did meet its endpoint and did show that there was a difference. Now, Ruby was not really statistically powered to look at this question. And so while it didn't quite while it wasn't quite as significant in terms of improvement, we can't be sure that, had we had more patients and had it statistically powered, that we wouldn't see the same degree of benefit that we're seeing with the GY018. So, what about moving beyond just the immunotherapy? What about combinations with PARP inhibitors? And so that's exactly what these two trials did. Ruby Part 2 included niraparib, a PARP inhibitor with your immunotherapy. Sorry about that. And this trial has completed accrual, and we're just waiting on the maturity of the data. This trial, Duo-E, looked at the addition of olaparib to durvalumab, which is a PD-L1 inhibitor. And and this data actually was presented by Dr. Weston at ESMO. And, you can see it did meet its primary endpoint, where the addition of durva and olaparib was when compared to control was better. And in addition, when durva was compared to control, it was also better. And then when you look specifically like at the pMMR subgroup, right, because that's the group that we can probably try to improve our outcomes in, I think we're seeing really robust improvements in the dMMR population. And so when you look at that data, you can see here that again, durva and olaparib did better than the control, but it's not quite clear what the benefit of the olaparib is, since here is just the single agent durva. And unfortunately, this trial, though we do see a benefit, it wasn't powered to detect this difference. So we don't really know what the relative, contribution of the olaparib is in this setting. So what about, and I'm going to just say we're going to have to wait and see what the FDA says and whether we're going to get approval for this combination. What about other opportunities in endometrial cancer? Is there a question? Did someone have a question, or should I keep going? I'm going to keep going.
No, keep going. Yeah, we'll do all the questions after.
Okay, I just heard someone. So, okay, so what about other maintenance therapy? So we have selinexor, which is inhibits exportin-1, and exportin-1 is the major nuclear transport protein for tumor suppressor proteins, p53 being one of the most important. And so inhibiting this inhibits oncoprotein translation and really enables p53 to do what it needs to and allow for apoptosis and cell death. So that's how selinexor works. It's an oral drug, and it was looked at in the SIENDO trial after, patients with stage 4 or relapsed endometrial cancer received their platinum and taxane chemotherapy, and then they were randomized to get selinexor or placebo, and I'll show you the data. And so when you look at the entire group, there was a marginal benefit, but when you looked at this subgroup with the p53 wild type, not abnormal, wild type, we saw a huge benefit in terms of the selinexor versus placebo. And so this, however, it was a pre-specified endpoint, but it wasn't powered to detect any difference. And when something is not a primary endpoint, it's really hard to make definitive conclusions. So what they are doing now is, based on this continued benefit, when they looked at the long-term progression-free survival, you see this continued benefit in the p53 wild type, and it was, the progression-free survival 5 versus 24 months, so very significant. What they decided to do, and then these are more data showing that regardless of whether they were microsatellite instability high or microsatellite instability stable, as long as they had a p53 wild type, they derived benefit. And this is why they are doing this next trial, which is Export EC. And we're all really trying to work hard to enroll on this trial so that we can then have this available to our patients and really, help in terms of maintenance therapy for this group of patients. And again, most of these p53 wild type are going to fall in that mismatch repair proficient, although there will be some of those that are mismatch repair deficient. And I did show you in that small subgroup analysis, they appear to benefit. So this trial is going to help us look at all of that more in a prospective way. Another cool target is MDM2, and it's a negative regulator of p53. And then this directly inhibits p53 transcriptional activity and transporting of p53 out of the nucleus. So, and then what it can do, MDN upregulation or overexpression can drive cancer cell proliferation. So when you inhibit them with inhibitors like naftamadlin, you can restore the normal function of p53, much like selinexor, which can then lead to cell death and apoptosis. So another very promising target. And another trial that we're doing through the GOG, where we are trying to look at p53 wild type patients and see if naftamadlin versus placebo is beneficial. What about, so we heard a lot about frontline therapy. I think we're safe to say that immunotherapy with chemotherapy is the standard of care with mismatch repair deficient endometrial cancer. There's, while there was benefit in the mismatch repair proficient tumors, there's still more work to be done, which is why we still have continued trials. And then now we'll focus a little bit on the recurrent tumors. And so the way I think about it very simply is, in the recurrent setting, your mismatch repair status is just as important because your therapies are dependent on it. And if you're mismatch MSI high or DMMR, pembrolizumab and dostarlimab are approved. And if you are microsatellite stable or mismatch repair proficient, then the combination of lenvatinib and pembrolizumab is FDA approved as therapy. So I just want to show you that in the mismatch repair deficient endometrial cancer populations, patients had a really nice response, to single agent immunotherapy drugs. Pembrolizumab and dostarlimab, as well as Durva, had nice responses, a little bit lower in avelumab, but smaller numbers of patients as well. So this is the data that from Keynote 158 that led to the FDA approval of pembrolizumab in the treatment of recurrent endometrial cancer. And again, you can see a very high objective response rate. And, these waterfall plots really show where all the responses are. And you can see quite nice reduction in the size of tumor. And then this is the Garnett study, which I played a very pivotal role in terms of enabling this study to be completed. And we now have this approved in the both in the accelerated approval setting for mismatch repair deficient endometrial cancer. And again, you can see here the beautiful waterfall plot in terms of response. And you can see here the objective response rate in DMMR endometrial cancer was 46%. What about the non-biomarkers? So the ones that aren't DMMR, the mismatch repair proficient, you can see that the response rate, the objective response rate falls off with Garnett, the dostarlimab and pembrolizumab having the highest, 13%. So which leads us to how can we improve upon that? So combining the immunotherapy with a TKI, tyrosine kinase inhibitor like lenvatinib. And so this was a trial that looked at pembrolizumab and lenvatinib and randomized them to standard chemotherapy treatments, doxorubicin or weekly paclitaxel. My friend and colleague Vicky Macker did this study, and along with everyone else, but she presented this data, and you can see here that in the mismatch repair proficient, there was a benefit and almost a significant improvement in your progression-free survival. And in addition, there was improvement also in your overall survival. And with that, this drug received accelerated approval in September of 2019 and regular approval in 2021. So it is the standard of care in recurrent mismatch repair proficient endometrial cancer. What about other therapies and the role of any non-IO regimens in endometrial cancer? So we already talked about XPO inhibitors and MDM2 inhibitors, but what about HER2 targeted therapies, antibody drug conjugates, and hormonal therapy in endometrial cancer? So HER2 is important in uterine cancer. You can see here in terms of the TCGA analysis of HER2 mutation. It's right up there in terms of its incidence. And you can see that this was a very early study that that my colleague and friend, Dr. Amanda Nichols-Fader, was the PI on, and it's a randomized phase 2 chemotherapy versus chemotherapy plus trastuzumab. And you can see here, both in the progression-free survival, that there was a benefit, to those that had trastuzumab. And this benefit was even more when it was utilized in the frontline setting. And the long-term overall survival benefit also was positive, both in the total population as well as the advanced seem to have the greatest benefit when compared to the recurrent. And that is what is now leading us to the phase 3 confirmatory trial. That was a phase 2 trial. And so we're now looking at stage 1 through 4B, HER2 positive endometrial serous or carcinosarcoma. And they're randomized to 3 different arms, just the chemotherapy with trastuzumab, or chemotherapy with trastuzumab and pertuzumab. And Britt Erickson is leading this trial. And in recurrent disease, I think, now that immunotherapy is becoming more and more widely utilized in the frontline setting, we need to really think about, other data in patients who've been exposed to a prior checkpoint inhibitor. And, these are two studies that looked at that. This first study was cabozantinib, another TKI with nivolumab, and they did have a prior IO cohort, meaning patients who received prior immunotherapy. It wasn't large, but they did see responses. And then this other trial that you see here was etigilimab with nivolumab, and this was an anti-TIGIT, and this had some very preliminary data that was presented at ESMO this last month with 10 endometrial cancers, and also seemed to have some efficacy. So this leads us to the trial that we have open through the GOG, which is the Podium 204 trial, and it is looking at different combinations. So if you have an FGFR mutation, you can go on a PD-1 checkpoint inhibitor with pemigatinib. And then if you've been prior checkpoint treated and are MSI high, you can go on the 3-drug regimen, the PD-1, the anti-TIM3, and the anti-LAG3. And so this is going to be some nice data to see what the efficacy is in patients who've had prior immunotherapy. And then what about p53 mutations and WEE1 inhibition? So p53 is loss dysregulates the G1S checkpoint, and then the WEE1 is at the G2M checkpoint. So if you use WEE1 inhibition in patients who have TP53 mutation, you get what we call synthetic lethality. And these are some of the WEE1 inhibitors studies that have been looked at in endometrial cancer. Adagio is the largest cohort with 167 patients, a phase 2 trial, and it had a response rate of 24% with a median progression-free survival of 5 months. This trial, this was proven to be challenging with a lot of adverse events, which is why the ZN-c3-1, another WEE1 inhibitor, which also preliminary data is looking promising. They are doing a dose optimization to really make sure they hone down on the right dose. And this is another trial that's ongoing to really look at the benefit of a WEE1 inhibitor in uterine serous cancers that have had prior checkpoint inhibitor. What about some of the newer antibody drug conjugates? I think all of you probably have heard that, antibody drug conjugates are here to stay. They first were approved in cervical cancer with tisotumab vedotin. Now there is an approval in ovarian cancer with mirvetuximab. So endometrial is next. And, these were two of the trials that were presented recently at our ESMO meeting. I actually presented the luveltamab tazevibulin, which is a folate receptor alpha targeting antibody drug conjugate that had early signs of anti-tumor activity, though a small cohort. And then we have trastuzumab deruxtecan, which, had some very promising efficacy with a response rate of 58% in a small cohort of 40 patients in endometrial cancer. And, given this data, it was listed in the NCCN guidelines as of September 20th as a treatment opportunity for patients who had 3+ or 2+ on immunohistochemistry of HER2 expression. So really this has been, kind of a remarkable journey with the trastuzumab deruxtecan. And then this is the first phase 3 antibody drug conjugate trial in endometrial cancer. And this is a TROP2 antibody drug conjugate. So this is a trial that we have open at NYU, and we are hopeful that we get this accrued and hopefully have another therapeutic option for our patients. Let's just talk quickly about hormonal therapy. Hormones have been around forever. Megestrol acetate got approved in 1971. It does have good response rates, but the issue is that the progression-free survival with these is short. So there have been combinations studied with CDK4/6 inhibitors and letrozole, which essentially more than doubled your median progression-free survival and really did show benefit, both in terms of progression-free survival and disease control rate. And then another older study looked at everolimus and letrozole, and they found that there was efficacy with the combination, and this is also NCCN listed as a therapeutic opportunity, and for those ER/PR positive tumors. So that being said, clearly we need a phase 3 trial looking at CDK4/6 inhibitors and letrozole, and hopefully that will happen, and we'll be able to also have that as a therapeutic option for our patients. So in summary, I think we can agree that patients with DMMR tumors have unprecedented responses to immunotherapy and should be the standard of care in the front line. And patients with mismatch repair proficient tumors also have improved outcomes. But I think, I think there is still opportunity to fine tune that and improve upon the responses that we're seeing, whether it be with other agents, such as selinexor or PARP. So I think we have to wait till all the data matures. And then lenvatinib and pembrolizumab is a standard after chemotherapy in mismatch repair in patients with mismatch repair proficient endometrial cancer. And then the role of immunotherapy after immunotherapy needs to really be looked at in a larger data set. We have very small studies right now, and most of our patients will be getting immunotherapy in the front line. So I think understanding the role after immunotherapy is important. And then, non-immunotherapy options, including HER2-directed therapies, antibody drug conjugates, and hormonal combinations are needed to provide better treatment options, and enrollment into clinical trials is crucial because that's how we've evolved the standard of care thus far, and we hope to continue to do that. And then finally, diversity in clinical trials is critical to ensure that new medicines work in the population expected to use the medicine. And I just want to thank you all. And I'm going to stop sharing. Yeah, we can maybe open up for questions.
Thank you so much, Dr. Pothuri. Very interesting. And it's great to hear about the advancements in the last few years and also the clinical trials that are going on now, which will make a difference in the future.
That's right.
So we'll start the Q&A. Thank you to everyone who pre-submitted questions when they registered. You can still submit questions now at the bottom of the screen. We'll try to get through as many questions as we can, but we may not be able to due to time constraints. I'm going to start out actually asking you about radiation, because a whole bunch of people asked about that. Is radiation still being done a lot as a frontline treatment after chemo, or is there a move away from that? Where do things stand with radiation?
Yeah, I mean, radiation is still an important treatment in endometrial cancer, but I think the way we think about radiation is really the early stage has the greatest benefit. And so that's where I utilize radiation, in the early stage endometrial cancer. And then sometimes I'll utilize it later in the disease course when a patient may have like an isolated recurrence. I utilize radiation. So it certainly is still an important part of the treatment of endometrial cancer.
And is that, so that does depend somewhat on the stage, whether you will use it or not?
That's right. Early stage is where we think about it.
Oh, okay, great. Thank you.
Yep.
Um, we had a lot of questions about some, very specific types of uterine cancer. I think um, there were a few questions about clear cell
Mhm.
carcinoma in terms of early treatment for recurrence, just overall, what kinds of protocols there are for that.
Yeah, clear cell cancers are a very, they're a rare type of endometrial cancer. Certainly, they are more aggressive, and we tend to treat with chemotherapy, even in early stage. The one other thing that people forget with clear cells are, they are quite radiosensitive. So that's another treatment option that can be beneficial, especially in the recurrent setting. And then there are some newer therapies that are directed towards clear cell because ARID1A mutations are common or frequent in clear cell cancers. And we now have targeted therapies, EZH2 inhibitors that target ARID1A mutations. So there's lots of clinical trials that are ongoing looking at these therapies.
Okay, great. Thank you.
Sure.
Um, Now I wanted to ask you, there were actually two questions about pelvic washings and how do positive results from pelvic washings influence treatment?
That's it's a tough one because you have to take that question in the totality of kind of the case. And, there's a lot of data that shows that, if you're going to do minimally invasive surgery, which is kind of the standard of care now in endometrial cancer, that, it's not uncommon if you use a manipulator to have some transtubal spread of cancer cells, and your wash may be positive because they may come out through the fallopian tubes. And so, but that's kind of more of a spurious type of wash. There have been a lot of studies that have looked at it. Many have not shown any impact on the prognosis of having these washes. So much so, and it was so controversial that they even took it out of the staging system. We still do the washings, but it does not affect your stage.
Oh, okay, thank you.
Sure.
Um, Somebody else asked about uterine carcinosarcoma. What are the best treatments for recurrence? Again, a rarer cancer. And which targeted options or other options might be good for that.
Yeah, so, all my endometrial cancers, I have molecular testing on, so I'm always looking for targeted therapies, especially in the recurrent setting. In carcinosarcomas, are an unmet need in terms of, treatment options. That being said, they were included in the Ruby trial. So we know that, we can utilize chemotherapy plus dostarlimab in the frontline setting. So in carcinosarcomas. So that's one therapeutic option. The chemotherapy backbone is still Taxol and carboplatin for carcinosarcomas. There was a phase 3 trial that looked at that and established that in carcinosarc. And in terms of other targeted treatments, so HER2 is overexpressed in carcinosarcomas. So any of these targeted antibody drug conjugates, trials with the HER2 antibody drug conjugates are great. And if you are 2+ or 3+ by immunohistochemistry, it is now NCCN listed. You could have access to trastuzumab deruxtecan.
Okay, thank you.
Sure.
Speaking of HER2, is that testing done by default now with other molecular testing?
Well, now that we have an NCCN listing, I think it's certainly very important. At our institution, we've been doing it for over a year now. That's mainly because we also have clinical trials that we can funnel our patients into. But now that it is NCCN listed, I think it's important that we all test our patients, especially in the recurrent setting, because that's where we can utilize these therapies. But I think, the story is still evolving with HER2 antibody drug conjugates, but they're here to stay. And they're going to be play a more prominent role in the treatment.
Thank you. Somebody's asking about Jemperli as a first-line immunotherapy treatment. And then part of that question said also, when used in second-line treatment for recurrence, how do oncologists decide when to use Jemperli or Keytruda?
So that's a great question. I showed you data for both, right? The GY018 was pembrolizumab, and then the dostarlimab, which is what Jemperli is the Ruby trial. Both had a benefit in mismatch repair deficient endometrial cancer. The one that's FDA approved is dostarlimab right now. So, if there's any insurance issues, there shouldn't be any insurance coverage issues with that. That being said, if your institution only has, sometimes it's a formulary issue. We have both of the drugs on our formulary, so we can use whatever we want as long as the insurance approves it. But sometimes you're limited by what's on formulary. They're both effective, as the data shows. And then the question of, do you use it in the front line or the second line? So always you want to use all your the most active drugs, if you have the data to show that it works, in the front line. You don't want to be saving anything because you really want to get rid of the cancer. I want to use my best drugs and anything that I can do to cure people in the front line. So I'm not going to save my dostarlimab or my pembro till later. And later I can probably utilize it in a combination setting. I just need a little more data, even if I've used it in the frontline setting.
Makes a lot of sense. Somebody is asking about, they have uterine carcinosarcoma. They're asking about olaparib because they are BRCA2 positive.
Yeah, I'm going to try to stay away from individual cases. And we don't really, the carcinosarcomas were not included in the DUO-E trial. So I can't really comment.
No, that makes sense. Thank you.
Mm-hmm.
Okay, let's see. What else we have? Okay. Somebody was saying, this is interesting, talking about the new protocol of Keytruda with chemo, that many doctors were not recommending it and they had to kind of ask for it. Is it becoming, much more this? I know it hasn't been approved for that long, but has it becoming?
Well, the Keytruda is still not approved. It's only dostarlimab that's approved with chemotherapy.
Oh, okay.
Right.
Oh,
So I think that's one thing. I showed you the data. The data shows it's active. It's just not FDA approved.
oh, okay.
And I think sometimes things just take a little longer to catch on. But I mean, these were, plenary presentations at our recent SGO meeting, over probably 2,500 people were in the room listening to this. There was a patient in the room. We had a standing ovation. It was really incredible. A patient who benefited from the trial. So it was really quite, compelling and really nice to see, the progress, and two, someone who had directly benefited.
Absolutely. Yeah, I was there.
Oh, you were there. Wasn't it amazing?
That
Yeah.
was amazing.
It was amazing. I'm still talking about it. Look at this. It's months later. Yeah. I took a little video of it so I could show my clinical trial teams how impactful the work we do is.
No, that's really fantastic. Somebody asked, speaking of clinical trials,
Yeah.
What is the best way to take advantage of and participate in clinical trials?
Yeah, you ask your provider, because, right, I mean, there are clinical trials are your opportunity to access all these new medicines. So I've used the HER2 antibody drug conjugates for over a year now because through clinical trials. And so I would ask your doctor about them. Is anytime you're about to change, my advice, anytime you're about to change therapy, ask about a clinical trial. even in the front line, once you get diagnosed, say, is there a clinical trial I can participate in? So always ask. And I showed some of the barriers, right? And that just not just applies to diverse patients, it applies to all patients too, right? The physician time and lack of knowledge and all of that. So I encourage everyone to be their own advocate. You know, I'm obviously heavily invested in clinical trials, so I ask all my patients, but not everyone, is as invested. So sometimes you have to be your own advocate. And yeah, and if at a time, where you're about to change therapy and you're curious, and if your doctor says they don't have a trial, then, find another, especially if you're in New York, there's different centers and we each have different trials. You can always go to one center, do your trial, and you can go back to your doctor. And I've done that. I've sent my patients, if I haven't had a trial open and, they had it in another site that I knew about, I've sent them there and then I tell them to come back.
Right.
So I think we have to really think more about what's best for the patient and not just, keeping the patient at your institution. So, and I think patients need to feel comfortable that it's okay to leave where you are for a clinical trial because not every site has them.
Is there a lot of collaboration within, like, say, in New York, within the
Yeah.
different hospitals, or?
I mean, some of us do, but in general, I find that we can do better on that front.
Right,
Yeah.
right,
Yep.
absolutely. Well, I think we're about to run out of time, so I think that's a good place to end on the good note of clinical trials and accessing them as often as you
Yeah.
possible.
That's
Um,
right.
yeah,
Ask
so
and get a second opinion, if you need to. NYU we have a great clinical trials program, and I'm not saying that just because I run the whole program, but Memorial has a really robust clinical trial program as well. So I would seek other opinions, especially, and you want to do it sooner than later because it takes at minimum 2 to 3 weeks to get on a trial. So as soon as you should try to get those appointments and start searching. That's my advice.
that's great. Well, thank you so much for a
Of
really
course.
great program. We really appreciate it. And we're going to have a recording of this program available on our website in 1 to 2 weeks. Everybody, please make sure to check Cher's website for upcoming educational programs and support groups, and follow us on social media if you can. And please take a moment to fill out the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. And all surveys are anonymous. So this concludes the webinar. Thank you again, Dr. Pothuri. We really enjoyed having you with us and appreciate all the wonderful information. And I hope that everyone has a great evening. Thank you.
Thank you. It was, yeah, great to share all of this. I love all the emojis. Thank you. Have a great night, everyone.
Good night.